So I want to introduce the first case, which is from Dr. Kasturi, presented by Dr. Kasturi. It's a high-risk PCI with Impella.
Dear ABC Chairman, thank you for giving me opportunity to present at ABC 24. My presentation is high-risk PCF calcific LM bifurcation, IVL modification with Impella support. This patient came to us with a cardiogenic shock, acute pulmonary edema. And when he came to hospital, he was in a gasping status. Immediately we intubated, and there's a markedly elevated lactate levels. Because of the desaturation, intubation was done. Next day, patient became conscious and he self-extubated. So if you see the angiogram, then we did angio shows severely calcified left main disease and extending into the LAD and L6 with a diminished flow, right coronary, PDA at the origin about a 50 to 60% narrowing. So because the angiographic calcification, what we thought we'll go with bifurcation stenting, whether to go with provisional or left main to do the IVS evaluation. Always see the extent of the block, severity of the block, is it extend to the main vessel or the main branch, side branch, and accordingly you can take the decisions. So always use the intravascular imaging while doing the left main bifurcation, and preferable to go ahead with the provisional stenting because the MACE rate is much lower with provisional stenting compared to two stents. But if there is significant side branch disease, long segment disease is there, large side branch is there, definitely we should go with the two stent technique. So before doing procedure, because the patient came with acute antival MI, we assess the cath. So right ventricular pressures are normal. There is markedly elevated LV, and we classified it as a LV dominant shock. So initially IABP support was given, then subsequently we exchange it to Impella. So Impella, always when you give a protected when you give MCS support, identify classify the sky stage. Is it a DR? It comes at a DRE. And at the same time, early MCS support you give. And at the same time, if patient is having biventricular support, go with even RV. If patient is having associated RV, go with early right ventricular support also. And RSC is the key factor to decide what type of MCM support a patient is going to require. And give the inotropes very short period and minimize the duration, and the number of inotrops are also reduced once you start the MCH. So this is IABP and the temporal pacemaker balloon tip, and you see the very significant reduction in LAD and L6 flow. Initially pre-dilated at the 1.5 and 2.5 mm balloons. So after that, again, we did with the 2.5 mm balloon dilatations, that is LM, LAD, and LCX. So then we thought that there is significant lesion. We were feeling grating sensation. Then we used IVL, 30 pulses per delivered to LM and 50 pulses to LAD, that is 3.5 into 12 mm balloon. Subsequently, again, we used the angiosculpt to modify it further. IVL is useful in superficial, deep, eccentric calcium and even calcium nodules. So, and assessed with very low complications. Dissection is low, slow flow, no flow is very, very low. And cutting balloon and angiosculpt definitely advantageous. The intramural hematoma, less chances, the melanocele effect will not be there. And controlled dissection, so less inflammation and more luminal gain. We were negotiating the stent. We were unable to place the stent. Again, dilate with 3 mm balloon, further modification. Again, retried but could not. Then we used the guideliner with inchworm technique, and mid-LAD was stented with 2.75 into 38 and proximal LM to LAD 3.5 into 48 mm. So after stenting, LSE got occluded. So when sudden occlusion is there, always assess the side branch and predict the side branch closure. If the long carina is there and at the same time block button is more, the chance of closure is more likely. And always keep the jailed side branch and jailed balloon. You should be familiar with the techniques like a jailed balloon technique, modified jail. There are various techniques. So operators should be familiar with the various techniques, how to prevent the side branch occlusion. And then we did the LM part. So when you do the LM part, if the part balloon is beyond the carina, it can compress the carina, it can lead to side branch occlusion. If you extend too proximal, it can cause the proximal dissection. That is also associated with increased mace rate. We used a supercross to place the wire into the L6 and dilate with 1.5. Now you got the flow. Again, we thought of opening the side branch with 2.5 balloon, but we were unable to place. And then we used the, see the guideliner, inch-worm technique, we placed in the proximal LCS, mainly to place the stent. And the stent was placed with guideliner help into the L6. And see the kissing balloon using the same stent balloon pulled down, and then 3.5 balloon in the LAD. Then we performed the repart. So repart again, it has to be done once you complete the final kissing. Still, we used NC again to do further kissings, and you should be familiar with the stent expansion capacity and avoid under expansion. L6 is more prone for under expansion, and if under expansion in two stenting has with a very high restenosis rate, so avoid the under expansion as much as possible. That is 24% versus 5.4. And this is the post dilatation with 3 mm balloon, and we use the OPN NC dilatation further to modify it further. You should know the technique of the kissing balloon, and both balloons should be deflated simultaneously. That is a very crucial point one should remember. And we used 2.5 mm NC and 3.5 balloon. So this is a final angiogram view. You can see nicely flowing vessels, LAD forward Timic grade 3 flow without any dissection. L6 is flowing very well. So careful analysis of the bifurcation with angio and intravascular imaging for plaque modification, morphology and distribution. And severely calcific lesions require adequate plaque modification prior to stenting and spade side branch occlusion and prevent the steps to the side branch occlusion. Once occlusion takes place, you should open it and provide the antegrade flow. Use a guide extension catheter to expedite the procedure, and always assess for the MLD max. That is very important. Perform right heart study to decide the how is the RV pressure, LV pressure, what is the what type of shock is there, RV dominant, LV dominant, biventricular dominant. Based upon that, you can choose the MCH, and early escalation and de-escalation strategies required to reduce the MCH-related complication. I thank once again from the bottom of the heart to Chairman, ABC, and all other executive members for giving me this wonderful opportunity. Thank you, one and all.
In this case, we have in the last consensus paper we have all the technique that he used to protect the side branch from occlusion. We start from the jail wire. When you have a jail wire and you occlude the circuit, you can go below the strut of the stent. If the balloon doesn't cross, you can use a balloon in the stented to like an anchor balloon and go below the strut of the stent to reopen. You can use a microcatheter, a Corsair has been described to go in this case. Sometimes when you have difficult anatomy like this, the jail balloon is, there are different from Buzzotta presented the first case many years ago of jailing balloon. There are modified inflated balloon. There are some techniques that can use in this high-risk patient because it was put Impella. So if you have a closure of the circuit, you should be pay attention to all this. I think that in this case, my opinion is that circuit should have been more protected than it was, and then the operator was able to reopen the circuit. But I don't see that a wire in the circuit when the circuit was occluded. So there was some strange, something happened and the wire was removed, or I didn't put a protection wire. So other comments?
I think it's a very nice case and very well demonstrates that left mains are probably different than regular coronary bifurcations. Now, what Remo said was quite important, and congratulations for the case that they were able to reopen the circumflex. But if the patient is in cardiogenic shock, I must agree with Remo that it's most important to at least keep it open all the time. I mean, the circumflex is a huge territory. The patient is already in cardiogenic shock. So at least to consider an upfront modified GL balloon, because the plaque moves there where there is some space, and there was no more space other than the circumflex. So I think this is what we do in our daily routine for left main PCIs in acute coronary syndromes, and there is basically no occlusion of the circumflex because we leave some space with the jade balloon, which is undersized. It's about the balloon to vessel ratio 0.8, and that's the reason that we can still, if there's some problem with the opening of the left main LAD crossover stent, we can still some crush or inverted crush we can do. So I think it's at the end it's congratulations because it's a very nice case, but demonstrates the importance of the left main LAD circumflex triangle.
Thanks. The only comment I had was that I didn't follow all the steps, and I was unsure whether or not there was any intravascular imaging to guide this case at the beginning. It seemed that, I mean, the operator's not here, I don't think, to answer the questions, but it seemed we went straight on to shockwave, but we don't really know what the ostium of the circumflex, what the plaque composition was there, whether or not that was calcified, and whether or not there would have been any benefit in shockwaving that as well, because we know that's the area that restenoses in left main bifurcation stenting, and whether or not there'd been some modification beforehand would have reduced the risk of the circumflex going down.